just indicate for me whether you are hearing me well. Um, Otherwise, I'm going to change my
Yes,
audio setting.
mashallah, loud and clear. Yeah, your voice is loud and clear.
Excellent. So today I'm going to talk to you about SARS-CoV-2 and COVID-19. I hope that by now people do know and differentiate between the virus and the disease. And just to briefly talking through the abbreviations, SARS-CoV-2 is the virus that is named after so many debate by the WHO of what to name this virus. And because it does cause the syndrome of acute respiratory, severe acute respiratory syndrome, it was called SARS, and CoV because it does belong to the coronavirus family. And it's given the annotation of 2 to differentiate it from SARS-CoV-1, which causes the endemic in 2003 in China again, subsequently had a spread to Canada and other countries. And the virus causes a disease that was later defined as COVID-19, which stands for corona, the CO, the VI for virus, and the D for disease. And the 19 is just to make sure that we do not blame the year 2020 because the endemic had started in 2019 December, but the disease was also declared pandemic in March of 2020, but as a disease entity was defined in December 2019 in the city of Wuhan in China. So you have to identify what is this virus. You have to be familiar with the virus. And any pandemic, you have to understand the relationship between the germ as well as the host, which is human in our case here. So this virus is extremely simple virus. It has a single-stranded RNA. I know that you hate virology, that's why you are in a family medicine, but viruses are either DNA or RNA. So coronavirus is an RNA virus. It's a single-stranded RNA virus. The nuclear material is inside here. You can see it. It's a small number of nucleotide as well. And it does have an envelope that you can see here, and it does have 3 major protein. These red ones that are called the spike protein, that you see them coming out, and this is what gives the appearance of the crown to the virus. That's why it's called corona. And it does have also the M protein, which is a membrane glycoprotein, and the nucleic capsid protein, the N protein, that these 3 proteins on the outside forms the envelope of the virus. This envelope is very, very weak, so it does dissolve very, very quickly. So you can easily destroy the virus with a regular cleaning agent that we use. You do not have to get a very corrosive cleaning material, so just a washing of the hand would kill the virus. Now, why it's important to know that this is an RNA virus versus DNA virus? Because RNA virus, when they go into the cell, in our case, the SARS-CoV-2, they go through the cell through the S-spike protein that attach itself to a receptor, and it happened to be the ACE2 receptor on the nasopharynx, in the lung, on the blood vessels, and the GI tract. It released the RNA into the cytoplasm of the infected cells. And because it's an RNA, it doesn't need to go to the nucleus to integrate itself into the DNA of a human, but it used the ribosome to replicate itself into the cells. And because it's in the ribosome, those people who remember their genetic and pathology and virology, they would know that in DNA, there is a lot of repair mechanism that happens. The DNA recombinase, DNA ligase, and so on. But for the ribosome, there isn't a lot of the correctional mechanism for any defect in the gene replication. And hence, RNA viruses are prone to a very high turnover of genetic variation. And that's why there is always a talk about whether SARS-CoV-2 would mutate into a different virus, whether it has a lower virulence that is infecting less than expected, or higher prevalence that is infected more people. So this is very, very important to know about RNA virus. And hence it makes it extremely difficult to develop a vaccine, because this virus can easily mutate with less correctional effect from the DNA repair. So when it infects the cell through the receptor, this receptor is ACE2 receptor. They go into the cell, they remain in the cell, replicating themselves for a couple of days, between 0 to 4 days. And this is the time where the patients might be asymptomatic, yet he is infected. And this is the time where probably there is no viral shedding into the tissue, and hence there is no immunological response, there is no fever, there is no symptoms, but you can detect the patient by looking at the virus itself, by antigen detection via PCR, which we will explain later. So now let's look at the virus when it comes here. This is simply a cartoon of the virus with the RNA and the spike protein. Here is the ACE2 receptor on the nasopharynx, where the virus enters the cell into the host ribosome. So again, it does not go into the nucleus, it goes into the ribosome, and hence it gets translated into genomic RNA replication. There isn't a lot of RNA repairs when there is the translation here. So we don't call this replication, we call it translation, and you would get the proteins, which are the spike protein or the M protein or the N protein to form the virus, and then the virus go and infect other cells. So here is when the virus enter the cell. It is usually on day 0, the first 24 hours, and then you have 1 or 2 days where the virus replicate in the airway cells. So you can't detect anything outside. Patient might be asymptomatic. And later, when the virus goes into the tissue, here where their immune system get activated. And we start with the innate immunity. We start with the, the complement, the neutrophil response that happens initially in order to engulf the virus to prevent it from going to infecting other cells. But we all know that innate immunity by itself is not effective to clear the virus. And here where your adaptive immunity comes by producing immunoglobulin, and initially it's the immunoglobulin M that will neutralize the virus and prevent it from going into the cell, and subsequently the T cell get activated and the immunoglobulin will be class shifted to IgG. This takes around 5 to 7 days. So if you do serology before this, it will be negative. And in most of the time, we do not depend on serology to diagnose respiratory viral illnesses such as influenza or parainfluenza, adenovirus, or any other virus. We usually depend on the deep nasopharyngeal swab or the bronchoalveolar lavage in case patients are intubated. What happens is most of the patient initially between day 0 to 5 have very mild symptoms, and suddenly after 7 to 14 days, the second week from having a very mild illness, they go into a very severe course. And this is where the T cell get activated and a lot of cytokine are released in the tissue, such as IL-1, which cause fever, IL-6, which increase the ALT and AST, the transaminases in the liver, and then tumor necrosis factor, which cause again fever and the septic shock picture that we see with the SARS-CoV-2 or COVID-19. And subsequently, the patient go into the picture of acute respiratory distress syndrome or severe acute respiratory distress syndrome, which is basically SARS. And this is where there is a lot of talk about probably it's the immunological response to a novel virus, to a new virus that the body have not seen that cause all this damage into the tissue. And when there is a tissue damage, then there is more immunological response that cause macrophages activations and so on. Do we have evidence for this? Yes, we do have some evidence from the cohort of patients from the Chinese populations. There is element of lymphopenia. There is element of increase in D-dimer, high cholesterol, high serum ferritin, and cytokines that indicate that probably there is a cytokine storms and immunological reaction that cause damage into the tissue. This translates into a radiological pictures where almost 70% of patients, if you do plain X-ray, you will see bilateral haziness, and more sensitive is when you do CT scan, you will see the ground glass appearance of both lungs. What is important here from a primary care perspective is you have to identify those people who present with mild symptoms in the first week, but they are at higher risk of developing severe diseases. So not to underestimate the mildness of the symptoms in the first week, because they can tip very, very easily on the second week when the cytokine storms, when the immunological reactions start to kick off. So this is very, very important to recognize that mild symptoms in a high-risk group that we will talk about should alert a primary care physician, family physician, to keep an eye on those patients and not to underestimate their symptoms. So what symptoms patients develop? Well, these are the list of symptoms that have been listed by the CDC in cohort of patients from the Chinese study that was published in the New England Journal of Medicine, where fever and chills is there. And just to remind you that in the Chinese cohort, fever was more sign of to the patient who have required hospitalization. But the patient who had mild symptoms, fever was only present on around 30 to 40% of them. So not all patients are actually febrile. Most of them had a temperature that is less than 37.9. cough as an irritation, like most of the respiratory viruses, shortness of breath and difficulty in breathing, especially the second week of the illness. This become very, very severe when the picture of ARDS and ground grout appearance on the CT scan appear. Most of the people feel very fatigued with muscle ache. Severe headache is one of those, and it was related to the fact because of angiotensin converting enzyme receptor is on the blood vessel, so tension headache might be associated with decrease in the vascular response to these patients. A new loss of taste and smell, and this is very, very specific, especially for patients who do have allergies, seasonal allergies. Usually they do not have loss of taste and smell, and this is kind of a differentiating sign or symptoms of COVID-19 basically, and the rest are the same. And again, nausea and vomiting and diarrhea is very important to identify. It's because then you would identify the route of a transmission, because patients who have symptoms of vomiting and diarrhea, they will not only shed the virus through cough and nasal and air droplet, but also through the stool, through the vomitus, which will alert you of how to advise the patients around the infection control precaution, especially if you are taking care of this patient or this patient is at home. Who are the patient at risk as been identified by the CDC? Older adult, those who are older than 55 years of age, their risk of mortality and morbidity is high, and it goes substantial if they are more than 65, and in almost 80%, if the patient is older than 75, then the mortality is extremely high. People with asthma, also at a higher risk, or any chronic lung diseases because of the existing damage in the lung. Those patients who do have chronic kidney diseases, again, because of the immunological storm and sandstorm and the antibodies, it is thought that the immune complex will worsen the kidney disease, very, very similar to systemic lupus patient. Patient with diabetes, immune compromised patient, although they are minority, but they develop a very, very severe case. Now, patient with immune compromise or patients on steroid, not only that they are prone to a severe disease, but they also shed the virus longer. They do not have a good T cell to control the virus, so they can shed the virus more than 10 days, more than 14 days. So for this population of patient on a steroid, immune suppressant, or immune compromised, they should be quarantined, isolated longer than others because they are prone to shed virus much more longer than others. When disease had spread beyond China, severe obesity was identified as a risk factor, probably because obesity is not a major risk factor in the Chinese population. So if you look at the Chinese cohort, you don't see obesity as a risk factor, but when the disease had become pandemic and went into Europe, Australia, North America, obesity was a major risk factor. And looking at the Kuwait populations, we can see that patients who are older than 65 with kidney disease, diabetes, obesity, they can make a hell of severe cases in these cohort. So let's move on, and how we prevent this. You have a virus that is highly contagious. It is less contagious than chickenpox, but is more contagious than SARS-1, is more contagious than MERS, than influenza. It is expected that one person would infect at least 4 people around them. So it's a very contagious virus. The more social distance you would provide, the better. The more transmission of air droplet by using a face mask or a surgical mask would help. As we said, the envelope is very, very weak. So hand washing, it's a very, very useful way of killing the virus, especially when you touch infected surfaces. As a healthcare worker, these are the recommendation for the COVID-19 personal protective equipment. This is the preferred one if you are taking care of patient with COVID-19, where you have to put on non-sterile gloves, the gown, the N95, the face shield. And the face shield is to protect not only the face and the nose, but also the eyes, because ACE receptor is found on the cornea as well. Those people who are taking care of patients who are suspected to have COVID-19, they can use the face mask, surgical face mask, rather than that. Now you have to be careful again, because if you are working in a high-risk area, such as the emergency department, or you are in an area where your clinic is in high endemic area, whereas there is a lot of patients, you have to treat this seriously, because the healthcare worker might be at risk. As I said, if you are taking care of patients who are immune compromised on a steroid, an immune suppressant, they might shed the virus longer. So again, you have to take extra precaution dealing with these patients. This is a table that is with the CDC about what kind of personal protective equipment you would need in either cases. So this is a guideline to use the personal protective equipment. Again, we have to balance between protecting the healthcare worker, the patients, and the visitor, and the availability of the personal protective equipment. And there are a priority list for the healthcare worker. Now, how do you diagnose the SARS-CoV-2 infection or COVID-19? Well, as we said, usually in order to diagnose a respiratory viruses, you need a nasopharyngeal swab where you collect the specimen. And because collection of the specimen does require a specific swab in a specific area with good sampling, sometimes in a hand that is not experienced in collecting nasopharyngeal swab, you might get low yield as a cell and a DNA. And then transportation is very important because, again, we said this is a very fragile virus. So sometimes it gets denatured and you don't get a good transportation of the sample, and hence you get negative, false negative, or equivocal results, and so on. So it's done by BCR technology, which requires special lab with a certain reactions, and you get the result expected within 24 hours to 48 hours, which means you have to deal with a person who is suspected to have COVID-19, yet is not confirmed. And what do you do as a family physician in this case in terms of advice that we're going to talk about, quarantine versus isolation? There was a lot of debate about testing, whether to use the serology versus the PCR. Well, each one does have a different indication. So viral testing, looking at the virus via PCR, it's to test for the current infection. So to confirm current infection, you need a PCR. If it's positive, most likely you have a current infection, and this person is shedding the virus. If it's negative, most likely the person does not have a current infection. Maybe he had an old infection, and now the PCR is turning negative if they have milder symptoms. The antibody testing indicate whether you have an old or past infection. If it's positive, likely this patient had COVID-19. But I want to warn with the fact that in respiratory viruses, because there is no viremia all the time, you do not activate your adaptive immune system all the time. So sometimes you get mild illness where the innate immunity take care of the virus, and you clear the virus without activating the B cell, without producing antibodies. So not everybody infected will have a protective antibodies. Only people who had moderate to severe diseases. In a report that was published by the Public Health Authority in the NHS UK, they have indicated that in the community with the widespread of community infection, only 15% of the population studied had the protective antibodies. So the herd immunity, the community-acquired immunity to SARS-CoV-2 is not going to happen in the coming few months. If you use both viral testing and antibodies, then if you have a viral positive by PCR and antibody positive, it means it's current and the patient have an active disease, but maybe in the second week of the infection where the antibodies are produced. If the viral is positive and the antibody is negative, probably this is an early infection where the patient have not developed antibodies yet. And if it's the virus PCR is negative and the antibody is positive, then probably this is a recovered patient. And if both are negative, probably this patient does not have the disease. Because of a high demand on the PCR, and because it does require a specific technician, procedure, reagent, and so on, the CDC had put a priority on which patient should have a higher priority of testing. So those patients who need to be hospitalized, or a healthcare facility worker who is in contact with person who had symptoms, or resident of a long-term facility, including those people who are on correctional facilities such as jails and so on. But it doesn't mean that for other patients who have mild symptoms or moderate symptoms, you don't do the test, but they are not a higher priority. So they will not be done on the first or second run by the lab. They will be done thereafter. So for public health purpose, they are a priority, but for a clinical purpose, high priority are patients who need to be hospitalized, need to be treated, because there are targeted therapy that will be started. What therapy is available? Well, this table summarized the medication available: hydroxychloroquine. And again, hydroxychloroquine and chloroquine families, they act on the envelope, destabilizing the envelope. So it's like washing your hand, basically. You can see that with hydroxychloroquine, there is a risk of cardiac arrhythmia. So in patients with cardiac illness, you have to be familiar with them. The chloroquine group in general, you have to use them in caution with patients with G6PD deficiency on in diabetic patients. The remdesivir, which is one of the intravenous medication as an antiviral. Basically, it does inhibit the RNA translation and hence prevent the virus from spreading into other tissue. And this is the study that was done in Japan. This drug was meant to be for influenza virus, but in Japan, it's on trial for COVID-19. The remdesivir and baricitinib, again, because we talked about the immunological response, it was thought that if we inhibit a little bit of the immunological response, maybe we can minimize the complication associated with immunological and cytokine storm, and hence anti-inflammatory Janus kinase inhibitor was tried, and this medication is used in rheumatoid arthritis to prevent the cytokine production, and it's in clinical trial for COVID-19 as well. And this is the rest of the other medication. Now, the convalescent plasma, which is a plasma from patients who have recovered from COVID-19, because they produce antibody and mostly IgG, it was thought that if we take the IgG from these patients who recovered and give it to a patient who is critically ill, this will act as a neutralizing antibody to the virus, and hence it would improve the antibody-dependent clearance of the virus. It is also being used in clinical trial. However, you have to be careful with the transfusion-related acute lung injury. You need around 200 ml of the convalescent plasma with an IgG neutralizing antibody titer of 1 in 640. Another medication that is immune suppressant is the interleukin-6 inhibitor, tocilizumab, and again, to prevent the immunological cytokine storms and hence decrease the ARDS. And we have heard of clinical trial on dexamethasone, again, to act on minimizing the immunological response and the cytokine storm. As a general practitioner, as a family physicians, you need to advise people about quarantine and isolation. So what is quarantine? Quarantine is used from preventive medicine department and public health to keep someone who might have been exposed to COVID-19 away from others. So these are healthy people who might be in contact with COVID-19 patient and might develop symptoms. And quarantine for COVID-19 is usually for 14 days because this is the incubation period. Whereas isolation is for patients who are confirmed to have COVID-19 so that they do not infect others. So what is the duration? If the patient is diagnosed with COVID-19 and you want to get them out from isolation, then this is the criteria. It's either symptoms-based or test-based. Symptoms-based, if they are free from fever for 3 days without any antipyretic, so no paracetamol, no Advil, their symptoms improved, such as requiring oxygen or shortness of breath. Cough might be going on for a couple of days, and 10 days since symptoms first appeared. So let's say somebody have the disease in June 1st, 10 days would be June 11, but then they should also be free of fever for 3 days before that, so maybe June 7 or 8, and symptoms had improved. If the test positive and you want to clear them and they have no symptoms, it's just the test was positive, then you go from 10 days from the positivity of the test. So if they have done the test on June 10 and it was positive, then they stay for 10 days. And this is not when the virus is completely cleared, but this is where there is a less chance of transferring the virus to or infecting other people. As I said, people who are immune compromised, have a chronic illness, are an immune suppressant, they might shed the virus longer than 10 days. If you are exposed to somebody with COVID-19, then the quarantine is for 14 days. This is the time where you watch for any symptoms and follow those patients. Now, as a physician, what do you do in your clinic? Well, there are so many guidelines from the CDC for hospitals, for a clinic, for a pregnancy, for whatever. But this is useful if you are sitting on your clinic and you want to develop a guideline of how you can manage patient. So before patient arrive, know which patient at higher risk. So from your patient log, who are the diabetic, who are the elderly, who are in chronic lung disease and hypertension and so on. Try to provide telemedicine appointment so that you don't need to bring these patients to a healthcare facility. Know how to contact the health department or the public health or preventive medicine, because if you're suspecting a case, then you need to contact them. Stay connected with the health department, knowing about COVID-19 status in the community to know who are the high-risk group, and then stock your supplies of the personal protective equipment. Communicate with the patient if they have any symptoms. At Beit Abdullah Hospice, we have developed what we call self-reporting respiratory visual triage checklist, where an employee would report on self whether they have fever, cough, shortness of breath, if they have been in contact with persons suspected or confirmed with COVID-19, and they record their temperature and they sign. If they have any of those symptoms, then they are asked not to come to the facility. They should call the IBC coordinator, the infection prevention control coordinator, or the preventive medicine or the ID person, and they should go to the nearest hospital. So these are some of the guidelines that are accessible by the CDC website on how to prepare your clinic. There is a guideline also. You will see people coming as a patient, getting an advice from you as a physician, whether they need to go to work or not. There is a nice article or perspective that was published in the New England Journal. It's called, Is it safe for me to go to work? Risk satisfaction for worker during COVID-19 pandemic. And it does have two axes. One axis looking at your occupational risk for contracting SARS-CoV-2. So either you are working in an office and administrative, you don't deal with patient, or you're working with home, your risk is very low, or you are contacting people who might be COVID-19, then your risk is medium, or you are actually taking care of COVID-19 patient and your risk is high. And then you plot yourself on the risk of death or complication. So younger age group, less than 55, with no risk factor, no diabetes, no hypertension, chronic lung diseases, obesity, to medium age or younger age with the risk group, or older, more than 65 with risk group, and you stratify. So if an employee is, let's say, 70 years of age, and he does have diabetes or hypertension, he should not be taking care of COVID-19 patient. This is C. Counsel patients on a high risk of continuing to work and to consider stopping work. Whereas if they are older, but they are working in an area where it's unlikely to see patients with COVID-19, still they can come to work. And this goes with the stratification that the Civil Service Commission had put, that in the early phases of returning back to work, pregnant employee, those who are taking care of handicapped patients, or those who are older than 55 years of age, diabetic, hypertensive, people with chronic lung diseases, heart diseases, cancer, renal failure, should consult their doctors. But I thought that this is a very good matrix. We did apply this to our employee. We have developed a questionnaire that I will share with you in a moment. This is a questionnaire that we have developed for our employee to come to work or not to come to work. It takes the age scale into consideration. So people who are less than 55, people who are older than 65. So this would be the very high risk group. This is medium risk group. This is low risk group. And then we ask them, where do they live? Because this is important. These are more information, so I can disclose them. If they are working in a quarantined area, if they are working in a lockdown area, then they are not to come to work in the early phases. And then we know that there is a lot of people who their spouse or family member are a healthcare worker working in hospital. So we often ask them about their living arrangement, whether they can quarantine themselves if they need to. Do they live in a house or an apartment or shared apartment? If they live with a healthcare worker, because they could be at risk. We ask our employees whether they are pregnant, do they have any health-related issue or any specific issues related to diabetes, hypertension, and so on, and whether they have been quarantined before or they have been tested positive. And based on this questionnaire, we then develop the risk assessment for our employee, advising them to come to work or not to come to work. And I'm sure when you go back to your practice, you will have a lot of patients who will come and ask you whether it is safe for them to go to practice or go to work, go to school, and so on. So I will end it here. I'm sorry I took 5 minutes more than, or actually more than that, than I expected, but I hope that this was useful.